Good morning, everyone. It's my pleasure to be here, and thank you for the organizing committee for inviting me to be part of this. Today, I'm going to be speaking about updates on IgG4-related disease. And my agenda is, I'm going to focus mostly on the pathophysiology, the updates in regards to the classification and diagnosis, focusing mostly on the clinical aspects of the disease. And then I'm going to summarize the approach to treatment, both standard and emerging therapeutic options. So over the past decade, 10 to 15 years, there's been a lot of excitement about IgG4-related disease as new advancement in the discovery of the pathophysiology of the disease has been ongoing. And as we all know, IgG4-related disease is an immune-mediated fibroinflammatory disease, which is characterized by mass-forming lesions in various organs. It is of subacute onset, and the hallmark pathological features are the, as we know, abundant IgG4 positive plasma cells and fibrosis. Many patients also have allergic features and modest peripheral blood eosinophilia. Now, before its recognition as a unified disease, the IgG4-related disease, there were seemingly disparate conditions and manifestations that were presumed to be unrelated. But we now know for a fact that these various conditions السلايد بس بتتحرك شوية are now all constitute part of the IgG4-related disease spectrum of disease, such as Mikulicz syndrome, renal thyroiditis, Kuttner's tumors, and so on. An important, in the update in the pathogenesis, an important discovery was actually found by Dr. John Stone, who's a renowned pioneer in IgG4-related disease. And what they did is they took a skin biopsy of a patient who had IgG4-related skin involvement, and they did a skin biopsy both before and after rituximab treatment. And as you can see from picture A, IgG4 positive plasma cells are strongly stained in the first slide, and 5 weeks post-rituximab, you can see after B-cell depletion, there is a significant reduction in the stain in IgG4. And what they did is trying to study the relationship between B and T cell role in the pathogenesis, is they did a CD3 stain of CD4 positive T cells. And what they noted is that B-cell targeted therapy also led to remarkable depletion in T cells as well. So this was a very important discovery in the pathogenesis. And what they did is they did a flow cytometry and next-generation sequencing of these CD4 positive T cells to try to delineate and define what kind of T cells these are. And this changed our understanding in the pathogenesis of IgG4-related disease. Because prior to this, we used to think that T helper 2 cells were responsible for the pathogenesis in IgG4-related disease. But this is now largely debunked, and now we identified these type of T cells, which are unique in that they are CD4 cytotoxic T cells with unique features. So, for example, they were noted that they secrete unusual cytokines, mainly interferon gamma, IL-1, tumor growth factor beta, which are very important in mediating fibrosis. Also, they secrete lytic enzymes, perforin and granzyme B. And a unique feature of these cytotoxic T cells is that they express on their surface specific special markers called SLAM-F7 or CD319. And this is just a representation of the pathogenesis. I won't go into great detail, but basically T follicular, there's various interplay between B and T cells in different various levels in the pathogenesis, which is very important. And T follicular helper cells are responsible for maturation of naive B cells into plasmablasts by means of IL-4 stimulation. And plasmablasts interact with the CD4 positive T cells with the various mechanisms, including the SLAM-F7, which secrete the various enzymes I mentioned and lead to fibrosis. Plasmablasts as well have a role in mediating fibrosis independently through LOX-L2, and also they secrete, responsible for secreting the IgG4 as we know, and IgE1, which is responsible for the complement fixation. Now, IgG4 itself does not cause, we do not believe that IgG4 itself is pathogenic in IgG4-related disease. So IgG4 is unique in its structure in that it is different than the other IgG subclasses in that it has a substitution of serine instead of proline in the hinge region between the two arms of the antibody in the antibody structure. So this substitution renders the hinge region to be a bit unstable. So what happens is when an IgG4 molecule meets another IgG4 molecule in the serum, it undergoes a process called a Fab arm exchange, which half molecule binds to another half molecule, and this renders IgG4 to be a bispecific antibody, which means it can bind two antigens at different sites instead of binding one antigen, and this causes it to be a weak kind of antigen, and therefore it does not have the ability to cause severe disease or bind complement and cause complement fixation. So we now believe that IgG4 actually plays a counter-regulatory role, which is kind of like an anti-inflammatory role, by means it migrates into inflamed tissues and kind of decreases inflammation in the tissues. So it's not actually cause disease. So IgG4 is useful for diagnosis and monitoring, but it does not cause IgG4-related disease. And this was also actually confirmed in an experiment where they injected IgG4 targeting pancreatic cells that express ovalbumin, and they injected them alone into these mice, and this caused no disease. However, when they Can somebody help me fix the slide? ايوه لا حافظة ممكن أتكلم كده يعني بس كنت معدت في مخي. طيب, when they injected IgG4 with ovalbumin-specific cytotoxic lymphocytes, this led to pancreatic inflammation, which indicates a synergy between, confirms the synergy between B and T cells. Okay, so serum IgG4, what's the importance? Why do we measure serum IgG4 if it doesn't really confirm it doesn't cause disease? So it's useful for monitoring patients who have a baseline elevation in IgG4, and it declines substantially with clinical improvement and re-increases with relapse. However, serum IgG does not normalize in up to 63% of cases after treatment, and it does not rise during disease flare in around 10% of patients. Also, depending on the method used in the laboratory, it can have false negative readings. For example, in Prozon phenomena, which also happens in other diseases, where there's an abundance of IgG4 and it would read falsely negative. So, serial measurements of IgG4 should not be used as a sole determinant of decisions about treatment. And this is just a diagram or a picture of B cell maturation, and as you can see from this, I just wanted to illustrate that B cells express CD19 throughout their maturation phase, from the bone marrow up till their migration into the peripheral compartments and lymph nodes. However, CD20 is expressed a little bit later on in the pre-B cell phase and is lost a little bit earlier. And this is, as we know, the target of rituximab. So there's a subset of plasmablasts and plasma cells that are not targeted by rituximab. And this is the reason why sometimes the IgG4 level would decline gradually with treatment. However, it may not normalize completely. IgG4 is also important as a baseline predictor of future relapses. So this study was also conducted by Dr. John Stone, which they looked at patients who were treated with rituximab, and they studied the predictors of relapse, and a baseline high serum IgG4 was found to be a predictor of future relapses in IgG4. So the higher the IgG4 at baseline, the likelihood of having a relapse was higher, and with a hazard ratio of 6.2. And this was also demonstrated similarly in regards to IgE and eosinophils as well, which were also found to be independent risk factors for relapse. So serum IgE and eosinophils are also elevated in 30 to 40% of patients. So we usually check for them. And this is also regardless of an underlying atopic background, which can be associated with IgG4. The increase in IgE and eosinophils actually correlates better with disease activity than IgG4 concentrations. Other IgG subclasses may be elevated, especially Ig1, and it's maybe the reason why we may have low complements in patients with IgG4, although IgG4 does not fixate the complement, but it may be associated with Ig1 increase, which is maybe responsible for that. It's important to check for complement levels C3 and C4 because they may indicate a subclinical or overtrenal involvement of IgG4, which is usually in the form of interstitial nephritis or a membranous nephropathy. Now, to make the diagnosis of IgG4-related disease, we need a combination of clinical, serologic, pathologic, and radiological features. We cannot rely solely on one of these features. For example, in cancer, pathology would be maybe sufficient for diagnosis of a malignancy. However, in IgG4-related disease, a lot of conditions can mimic IgG4-related disease, both clinically and histopathologically. So it is not sufficient alone by itself to diagnose IgG4-related disease. For example, ANCA-vasculitis and a number of neoplastic and inflammatory conditions can have histopathologic features that mimic IgG4-related disease. Furthermore, IgG4 levels elevations are not specific to IgG4-related disease and can be seen in a number of other conditions such as sarcoidosis, various dermatological conditions such as pemphigoid, and so on. I will not go into great detail about the various clinical manifestations due to the time. However, we now believe that IgG4-related disease manifestations fall into 4 clinical phenotypes. And this was actually described in more detail in the latest ACR-EULAR classification criteria, which was published in 2020. And this is important for us as clinicians because they noted that each clinical subtype behave a certain way, are at risk for certain factors, and respond to treatment differently. So, for example, patients with head and neck limited disease tend to be more female, more Asian, and younger, as opposed to the other subtypes, which are usually male, older in age. Also, ESR and CRP is usually normal and non-specific in IgG4-related disease. However, they noted that patients with retroperitoneal fibrosis and aortitis may have elevation of ESR and CRP that can be used to monitor therapy and treatment. Now, as regards to radiological findings, PET scan is non-specific. It's helpful for staging of the disease and for monitoring of disease treatment. However, it does not differentiate between reactive lymph nodes and lymph nodes that are involved by IgG4-related disease. There are certain features that are on the other hand, there are certain features that are highly suggestive of IgG4-related disease and very specific. For example, the presence of a sausage-shaped pancreas, as we know, is indicative of autoimmune pancreatitis, which is very specific for this finding with the surrounding rim of hypodense tissue, which indicates edema, is very specific for IgG4-related disease. Also, the evidence of PET scan involvement of the submandibular glands and pancreas simultaneously is also very suggestive, and the evidence of involvement of multiple swellings of more than one salivary gland and lacrimal gland is also very suggestive. Other features that are also suggestive is the evidence of paravertebral band-like soft tissue and circumferential tissue retroperitoneal fibrosis that's extending around the infrarenal and iliac arteries specifically. The pathological features are all well known to all of us, which is basically the lymphoplasmacytic infiltrate and storiform fibrosis, as you can see from picture A in the H&E stain. And the storiform fibrosis is basically a swirling type of fibrosis, which is like a mat, from Latin of mat, and This kind of pathology is usually demonstrated in all organs involved by IgG4-related disease. Regardless of the organ, you will see a similar pathology. The immunohistochemistry, what they do is they stain for IgG, and then they see the proportion of IgG4 positive cells, and a ratio of more than 40% is very suggestive of IgG4-related disease. I'm going to touch very quickly on the important clinical aspects of the classification criteria. In short, it was around 1,879 patients, and the criteria were validated in 2 cohorts. They have a very high specificity, and this was because they wanted to include a homogeneous group of patients for inclusion in research studies. So the first step, the criteria undergoes a 3-step process. The first step is a major entry criterion. So patients have to be, they have to have this entry criterion in order to enter the classification. And basically it's involvement of a typical organ, which is one of 11 organs that they mention in the classification, which includes the orbits, pachymeninges, salivary glands, specifically renal thyroiditis, bile ducts, pancreas, kidneys, lung, and aorta, and retroperitoneum. So you can see that if a patient does not have one of these typical organs and has an atypical organ involved, they may not be classified as IgG4, so there's a risk of having a false negative in these because of this very high specificity. Then the patients undergo an exclusion criteria. The exclusion criteria are either clinical, serological, pathological, or radiological. Fever is not a very common feature. It's one of the exclusion criteria because the presence of a high-grade fever is actually not very typical of IgG4-related disease. Similarly, a lack of response to glucocorticoid excludes a patient from classification because patients with IgG4-related disease are usually very responsive to glucocorticoids. Serological exclusion criteria that are important, examples include the ANCA, specifically against PR3 and MPO, which could mean the patient has vasculitis, anti-Ro and anti-La, Sjogren's, and so on. So anybody with any disease-specific antibodies is excluded from classification. Radiological findings, any patient with radiological progression that's really rapid, they consider that not to be suggestive of IgG4-related disease, so they're excluded because it could be infection, vasculitis, or something else. In the pathology exclusion, prominent neutrophilic inflammation, necrotizing vasculitis, necrosis, granulomas, which can indicate sarcoid or vasculitis, so those are excluded. After the exclusion criteria, the third step is the various domains and items, and they're all given scoring points. A case meets the classification if the entry criteria, the first one, is met, there is no exclusion criteria, and the total point is equal to or more than 20. Okay, so now I'm just going to move to treatment. It's important to recognize IgG4-related disease in the early phases because in the inflammatory phase, the patients are usually very responsive to treatment and the organs are more likely to shrink. However, when patients progress into the fibrotic phase, response might be a little bit refractory. So it's important to catch these patients in the window of therapeutic opportunity. So who should be treated? In general, symptomatic patients, patients who have biochemical or radiological abnormalities that are detected, and asymptomatic patients who have worsening progressive disease in vital organs. For example, patients with hydronephrosis causing renal impairment or retroperitoneal fibrosis with involvement of the aorta or aneurysms that might cause dissection. Surgical intervention may also be needed, such as stenting and so on in urgent cases. In asymptomatic patients, a method of watchful waiting and regular monitoring may be reasonable. There's a minority of patients who actually resolve spontaneously. Therapy aim is, as in all rheumatic diseases, induction of remission. Usually this is by means of glucocorticoids. And remission is usually clinical, radiological, and biochemical. And it usually occurs within days to several weeks. The usual dose that we use is 30 to 40 milligrams of prednisone per day, which is usually around 0.6 to 1 milligrams per kg of prednisone or equivalent. And usually this is given for 2 to 4 weeks and tapered by 5 milligrams every 2 weeks over 3 to 6 months. The Asians and the North Americans differ in their tapering. So the people in Japan and China prefer to keep patients on a small dose of prednisone, 2.5 to 5, but in North America and Europe, they're more glucocorticoid sparing, so they prefer to taper it completely off. High-dose pulse methylpred may be used in very urgent organ-threatening manifestations. So there was a retrospective study comparing high-dose prednisone versus medium-dose prednisone, and it showed no difference in terms of remission rates. However, of course, there was more frequency of relapse in the medium dose. Immunosuppressive therapy can be added to first-line glucocorticoid therapy if predictors of relapse are present, and I mentioned before the predictors of relapse, which is a baseline high Ig4, IgE, and eosinophils, as well as multi-organ involvement. Options, there's no randomized controlled trials assessing these different immunosuppressive agents. However, success has been reported with azathioprine, Cellcept, methotrexate, leflunomide, tacrolimus, and cyclosporin and several other agents. Most of the data is derived from retrospective studies. In 4 controlled prospective studies and 1 randomized study, DMARDs and glucocorticoid therapy led to a higher remission rate compared with glucocorticoids alone at 6 months. And there seems to be some success with Cellcept specifically. Cyclophosphamide, although I wouldn't use it in non-organ threatening. And iguritimod, which is only approved in Japan. We don't have it in our countries. It's approved for rheumatoid arthritis. In a meta-analysis of 15 observational, uncontrolled, non-randomized clinical trials, higher remission rate was seen in patients who received combination therapy of glucocorticoids and DMARDs over either alone. Now we move to biological agents. We all know rituximab works very nicely for IgG4-related disease. It's the most biologic with experience in IgG4-related disease, and it does lead to remission in a lot of cases, 67 to 83% of cases, but this was from an uncontrolled, non-randomized prospective and some retrospective studies. So we believe that rituximab leads to B-cell depletion, CD20 positive B-cell depletion, which leads to no repletion of the plasmablasts that produce IgG4 and a rapid decline of serum IgG4. And it also works by inhibiting CD4 positive T cell depletion, and this would lead to resolution of the cellular infiltrate and rapid shrinkage of the organs. Now, the dosing and timing, it's been used in different studies, different protocols. So they used the 1 gram twice rheumatological protocol and the 4 infusions weekly. And some studies use the lower dose of a single infusion. They've not been compared in any head-to-head trial, and they all worked the same. So, in regards to maintenance therapy, the selection of patients who need maintenance therapy and the modalities of treatment administration remain unclear and based on expert opinion. And it may be indicated in patients with a high risk of relapse, patients with organ-threatening manifestations, and it basically includes low-dose glucocorticoids and steroid-sparing agents as well. Listen, ما في 1 minute. وعلى كيفك. طيب. Immunosuppressive therapy, there's mixed results. So some studies show that the addition of DMARDs revealed no difference in terms of relapse-free survival, and some studies showed some promise in the use of MMF again, and some positive experience with other drugs such as tacrolimus, azathioprine, methotrexate, and leflunomide. However, rituximab performs better than the other DMARDs in reducing rates of relapses. Time. The optimal duration of therapy, there is no consensus about the exact duration of therapy. A commonly accepted strategy would suggest continuing maintenance therapy after 3 years of persistent serologic and radiological improvement. And of course, with regular follow-up. In relapses, usually we treat with the same regimen that was used for induction of remission, and usually works, and we try a slower tapering of glucocorticoids. In the last minutes, I will just mention a few of the emerging treatments which have been discovered based on our new understanding of the pathogenesis. And there's a lot of ongoing trials which are very exciting. So the first drug is Xmab 5871, which is a humanized bispecific monoclonal antibody directed against the Fc gamma receptor and CD19 on the surface of B cells. And inebilizumab is actually a study, it's the first international trial on IgG4. It's an anti-CD19 antibody. And it's undergoing a trial, a phase 3 randomized double-blind multi-center placebo-controlled trial. And I think this might be a good drug because it will deplete all phases of the B cell, all stages of B cell. It will lead to significant B cell depletion. So inebilizumab. Elotuzumab is actually directed specifically against SLAMF7, which is the specific surface marker on cytotoxic T cells and B cells, plasmablasts that I mentioned before. So this is also undergoing in a clinical trial being studied. Last but not least, the rilzabrutinib, which is a BTK inhibitor. It's a molecule that works by inhibiting Bruton tyrosine kinase, which is important for B cell signaling inside the B cell, which is also plays a role in proliferation and survival of B cells. So that's also undergoing clinical trials and being studied. Abatacept is in early phases of trying to see if it works as well in IgG4-related disease. Leflunomide is also being studied in an open-label randomized controlled trial in 70 patients. And belimumab, which makes sense, is also being studied, which is a BLIS, it blocks BLIS, also studied in China, and they're comparing it with glucocorticoids plus versus glucocorticoid alone to see if it has any effect on relapses. So in summary, IgG4-related disease is a multifaceted disease and a great mimicker of other conditions. The histopathology still remains the key to diagnosis, but like I mentioned, we need a subset, we need a combination of clinical, serological, radiological, and pathological to make the diagnosis. It's highly treatable and responds promptly to glucocorticoids, but there's a lot of relapses, and prolonged courses of glucocorticoids are often needed, and the addition of rituximab or other immunosuppressive therapy may be needed because of this high risk of relapse. Rapid advancement in an understanding of its pathophysiology is leading to the identification of novel therapeutic targets and possible personalized approaches to treatment. Thank you very much for listening.